Good afternoon. Um, I think that I've been so excited today because all the speakers, all of us, it's like we all talked and stacked our talks to match and to brainwash you. But honestly, none of us today knew the PowerPoints of the other person. I'm Shannon Dial. I'm here today on behalf of the Chickasaw Nation. I hope to bring a little bit of perspective of what's happening in Indian country and Indian healthcare for you, and share a few things just about tribal healthcare systems also that I think every time I talk to people, the questions that people ask about tribal healthcare systems are really amusing, and I think a lot of people don't understand. So I wanted to just give you a couple tidbits today that might help you in just understanding the landscape of Indian healthcare in Oklahoma. Um, Today, everything that I'm going to share with you and all that's been possible at the Chickasaw Nation is because of the amazing visionary leadership of Governor Bill Anatebby. And if you've lived in Oklahoma a minute, you know how revered Governor Anatebby is. And the things that we're talking about today, integrated care, uh, zero suicide, collaborative care. We've been working on these things for 8 to 10 years now, and it's because of the true foresight of the leadership in the Chickasaw Nation to want to be cutting edge and to allocate funding throughout this entire time to truly do whatever we want to do for the mental health landscape at the Chickasaw Nation. If you're used to working in healthcare or maybe for the state, you're used to being a penny pincher in mental health. And at the Chickasaw Nation, we're fortunate to not have to be penny pinchers and to have all the resources that we need. The other thing that I think is really interesting to Oklahoma that I think is great, and we do talk about a lot of the bad, but some things I've been really impressed with the past couple of years is the opportunities for mental health professionals in Oklahoma to actually make money. When I started as a mental health professional in Muskogee long ago, my salary was $28,000 and I saw 40 patients a week. And now we're hiring therapists at $70,000, $80,000 straight out of school. So I think it's the first time that mental health professionals are able to make money. And I'm so proud of Oklahoma. Most everywhere that I've been has really raised their salary caps to be able to reimburse mental health professionals adequately. And I think that's so great. Also, the most recent statistics that I've received from the state did show that we improved our abilities in Oklahoma to manage those who were suicidal and a reduction in suicide deaths. So I just wanted that to be in your minds today. So today you'll probably already know a lot of things about what we've shared. As I've said, the guys today have shared slides that are just very similar to what I want to share with you. So we'll be able to skip through a few. I hope some of the things that I present to you at least stacks it in a way that gives you an elevator speech so that the rooms that you are in and the conversations that you are in, you can harken back to this presentation and maybe instantly kind of be able to put a few concepts together that could truly bring systemic change in wherever you work. The discussion that I want to have with you today is really about ideas that are applicable to both adult and pediatric environments. We're doing these things in both settings. So if you're here representing pediatrics, I hope that you feel welcome to this conversation as well. Also, the emergency room characteristics that I talk about today is not any disrespect to emergency rooms. I'm mainly talking about our own emergency room and what we've learned, but also in some emergency room discussions that I've been in with emergency room leaders across the country and their feelings of inadequacy in managing suicidal patients. Lastly, I wanted to ask you today to think about something that I think is interesting, and that is whenever I have a personal friend or a colleague that has somebody that is in their family that is suicidal and they begin to start navigating the mental health system in Oklahoma, they're like, can you believe what we've been through? Do you know what happened? We went to the ER and we were there for 2 days. I mean, they're just absolutely floored. And I don't know if you guys in healthcare have experienced that, but I think most people in general don't understand what it's like navigating our healthcare systems as mental health patients and patients that are suicidal until it does happen to you. So please think about today, your own experiences in your family, or that you may have had or will have potentially, and having to navigate our systems. So, um, emergency departments who are not integrated are really ill prepared for managing patients that are suicidal. They have told me when I speak to emergency room physicians that they desire more than anything to be able to manage a suicidal patient in the emergency room, but they don't have the consultants, the resources, and the time available to them. They are unequipped. I do know some emergency rooms in Oklahoma that have integrated and are equipped, and it's wonderful. So I'm really talking about emergency departments like ours before we were integrated and what was encountered in our emergency room by patients who were suicidal. In the emergency room, the options for intervention are limited. We're usually limited by time, space. The providers in the emergency room tell me that their philosophy is to treat and street. And if you can think about the philosophy of treat and street for somebody that's suicidal, it's not really always the most welcoming place for somebody in a mental health crisis. What I have noticed is that when our patients at the Chickasaw Nation, at least, leave the emergency department and move to inpatient treatment, whether urgent care to inpatient or straight to inpatient or straight to urgent care, I've not gotten one patient review back that said it went amazing and it was a wonderful experience. So if you guys have, please let us know your secrets. Um, I haven't met anybody that is actually willing to actually do it again. And so it makes me kind of nervous when people have a bad experience that the next time that they're suicidal, that they won't endure this again. Regarding boarding, some people on the West Coast showed me a live dashboard where they track pediatric boarding for patients waiting for inpatient beds. And I don't know how that is in Oklahoma, outside of our tribal healthcare system. But the pediatric boarding rates right now, at least from the dashboard that I was studying of about 7 or 8 states, children were in the emergency room needing inpatient treatment for like 4 to 6 days. I asked our emergency room physicians for us if we have that issue. They said that they could think of 2 cases where a patient was so complex we couldn't find them a bed if they needed one. We moved them to the acute care and boarded them in the acute care, but they were not boarding in the emergency room. I have consulted on a couple cases in Tulsa where children were waiting 6 to 8 days in the emergency room. So boarding is another reason for both adults and children that I don't believe the ERs are the best place for patients that are suicidal, except obviously in the most extreme cases. Emergency rooms and ours is no different. When you say a patient is here for suicidality or is suicidal, it is just that they are suicidal. There is no low, moderate, high risk. They treat everybody the same. So at the Chickasaw Nation, when I came, every patient that was suicidal all got shipped out, every single one, and everybody knew it. So if you said suicidal, we don't have inpatient facility, you left the Chickasaw Nation and went to a facility in Tulsa or Oklahoma City or Dallas. So the importance of risk stratification and categorization of level of risk in the emergency room is really important, and often the time and logistics to make that happen aren't present. I had to listen to a patient complaint recently about her experiences in our emergency room and in her transition to an urgent recovery center and then to an inpatient treatment facility here in Oklahoma. And she said nobody at any point in all 3 places ever asked me why I wanted to die. And it rocked me to my core because she had been mulling over the reason that she wanted to die for months and months and months. And it finally got her to the point where she wanted to die by suicide. And everybody that she encountered in the system never asked her why. Even in the therapy that she was in, everybody was just like, how are we going to keep you safe? What things do you have in your household that might increase your likelihood of suicide? But in all those transitions and all those professionals, nobody ever listened to her story. And she was patiently waiting at every stance to be able to tell her story. And so that just recently struck me. And again, that was due to a mishap that we had. So I'm letting you know we're still figuring a lot of things out. Nurses, doctors, again, that she encountered, they mean well, but they're not there and not there to have the time to listen to her story of trauma. The risk for suicide, death, or attempt is higher within 30 days of discharge from emergency departments. The Joint Commission has, for like 20 years or 25 years, something, had as the top 5 sentinel events of major incidents in hospitals that people leaving the hospital within 72 hours of being in their care have died by suicide is still one of the most common medical events in all of healthcare. Up to 70% of individuals who leave the ED after a suicide attempt never make their first outpatient appointment. We talked about that today. Emergency departments really need a program that's designed to fit their workflow and takes into consideration all of the barriers that they have. Ideally, this is what an emergency room might have that would make them the ideal setting. Do any of you guys know, again, I just work in Ada. Does anybody want to give a shout out to emergency rooms in Oklahoma that do this well? Just, you guys are from more urban areas. Does anybody know in Oklahoma any examples of emergency rooms that do this great?
I work at St. Grant. I don't think we do it well, but take the clothes, someone's away, so we could find a service.
Yeah.
Then as a PA, for some reason we make a lot of LMFT forms.
Yes.
I'm not really licensed on it.
Interesting. Interesting. That's for them to transport and be under EOD. All right. So I wanted to make the case for you that primary care, as we've discussed, is the setting in which Americans receive most of their health and behavioral health care. Frequent contacts and a long-standing connection and relationship with a primary care provider, as well as the nurses and the front desk people and all of it, make it the ideal situation for addressing suicide prevention. We've talked about all of these statistics here. Today, we've even used the same statistics, so I will not repeat those to you. There is a lot more. I just saw the MIPS measures. I don't even know the acronym MIPS, so I owe $1 to the jar. But I just saw the MIPS measures for 2023 are even more detailed about the management of depression and suicidality in primary care. So I do think the payer sources and accrediting bodies are on to this idea that primary care is a good place to address these. So I want you just to imagine a longtime primary care patient named Jamie shares with her nurse that she's been having thoughts of suicide. The nurse alerts the provider. The provider refers the patient to the ER. And then what happens next? So what are some questions that you would have about Jamie? If Jamie was your patient, what do you want to know? She went to the ER for suicidality, and then what? Yeah. How at risk was she? What else do y'all want to know? Is this the first time that she attempted or is maybe suicidal? What precipitated it? What's her story or her why? Good. Did she have a plan? Now, I think the primary care doctor just heard that she was suicidal, so I don't know if the primary care doctor knows if she has a plan or not, depending on their training in that primary care setting. Anybody else? What do you want to know? Yes. Say that again. Yes. How frequently the ideation is happening and how severe? How is life? Yes. Yeah. Yes. Yeah. Social determinants of health, family. Where does she live? Um, yeah. Is substance use involved in connection to the suicidality? Does she have the means to complete the plan? How's how is school? How's life? All right. So these are just some questions that I thought of. Was Jamie a low, moderate, or high risk for suicide? Did Jamie go to the ER? Did she need to go to the ER? When she got to the ER, how did it go with the ER? I literally don't know for you guys, primary care wise, what you find out once you send somebody. I think through the HIE, you could probably see some shared records. How long was she there? Did she maybe decide that she was no longer suicidal after she boarded there for a while? How does the primary care team know what transpired there? Did someone request the records? If the mental health records were not in the HIE, what would you do and who would request the records? How do you prepare to receive Jamie back from the treatment that she got in the emergency room or maybe subsequently somewhere else? Does she have access to lethal means? Does she know the primary care team cares about what happened to her after they sent her to the emergency room? And what's Jamie going to do the next time that she feels this way? So to me, the answer is a bridge. We need a bridge and we need an assist in primary care to be able to help us find out all of those things. This bridge is built by the Chickasaw Nation and the Chickasaw Nation Recreation Area. I thought it was a great image for us to think about bridging integrated care. So we've talked about integrated care nonstop today because it is the buzzword of the day. If we were in church and as Jesus is the answer, integrated care being the answer today, we would all be doing great. We shared about just some basic history, but knowing, I guess, that integrated care has existed in conceptualization since 1977, I'm just so confused why we're just now training residents and mental health providers and everybody in integrated care. It just seems like such a duh moment to me that I don't know why we ever began in siloed ways anyway. So we talked about today the different varying models of integrated care. The tree image is a great one that we saw earlier. This other scale of integrated care, I believe, is from SAMHSA and has a lot of great details. So bridging again from integrated care into zero suicide. I know you guys have all heard the term zero suicide, and we've probably heard it in a few different ways. I did want to let you know that it is an actual model, and that's what I wanted to talk about today. And the reason that I want to talk about so much this being an important model is that it is so clear cut and so specific about what you need to do to transform your practice. I can't even believe it exists and that it is so easy to read about, not easy to transform in your system. But I did want to make sure that you know that zero suicide is a model that was developed by an amazing task force that it's been around as well for quite a while. And so today I want to refer you to the Zero Suicide website that has every resource possible on this model. It is in thousands of healthcare settings in the country. I've been to many. Everybody is doing wonderful that has started this, a lot of tribal health systems as well. The zero suicide philosophy Manual, ownership, copyright, brand is owned by the EDC, the Education Development Center, which also houses the Suicide Prevention Resource Center. If you look on the website, you can learn about all of those things. Zero suicide is so great because it fills all the holes in the Swiss cheese. It states the goal. It provides opportunity for suicide care management to be something that we all do. It includes all the uses of all the EBPs or evidence-based practices that are out there. But most importantly for us is that it aligns with the Joint Commission. If you work in facilities where you feel like you hear the word Joint Commission every day of your life, when you find something that is compliant and consistent with the Joint Commission, people are open to it in a way that they're not open to other things. So we're very fortunate that the Joint Commission has endorsed zero suicide, and I feel like legitimizes it even further. So not to go through all of these elements today, but just this is an example of how I was telling you. It's a very clear step model. These are the 7 steps. Under each step, there's milestones and mile markers and evidence-based tools that you can utilize. This is what we did from the top to the bottom, follow the list. It was to me, very systematic and standardized. So obviously we've talked today about primary care, integrated care, and zero suicide. And I would like to make a case today that I believe this is the perfect trio. I would get a tattoo of the trio if somebody offered me a lot of money. So this basic, you can Google zero suicide and click on images and find a billion different things. This is Vermont's model that they have. I thought it was really, really great. This is kind of the steps of zero suicide implemented into the emergency department on the left and into primary care on the right. I thought it was just very clear cut. Again, supporting why I believe that the steps and knowing kind of what you need to do in your care system to be compliant and thorough and helpful and supportive of people in this crisis time or pre-crisis time or contemplation, all of those things at the different stages. It kind of allows you from prevention all the way to the highest intervention to see where people are on the map and to see where your practice can excel. Just some great articles that have made the application of zero suicide to primary care for the nerdy ones of us that like to read. One of the great articles that have studied this, again, made this great workflow that is so wonderful because, again, to me, it just allows your nurses, your doctors, everybody to know what steps to take. So if you see at the top box, this is who's going to get the screeners. Patients that are, this is the people that you should consider getting the screeners. The patient is new to your practice. They haven't had a suicide screen in the last 12 months. They have had a positive suicide screen in the last 12 months. Or they have a current psychiatric diagnosis or clinically significant diagnosis or substance use. So this kind of begins to guide you, and you can see as you go through each step, if they're positive here, you move to the next step. If they're negative here, we can go to this step. So it's just very, very clear to me. And at the bottom, you can see that the blue is for those that identify as low. The yellow is those that maybe are moderate, and the red is those that are imminent risk, and those might be the ones that you managed more in the emergency room. But I do believe you could manage those in primary care. This is in an article by Horowitz. So as part of the transition element in zero suicide, I'm most passionate about the transition element because I believe that transitions are absolutely where we lose track. When I manually track the patients and where we lost communication with them, it's always usually because we sent them to another facility. And there's a variety of reasons that they are off of our radar. The least moves to me are the better. I actually encourage our staff to not send people to inpatient. So remember I said in RER, we would send every single patient who is suicidal to treatment. So we've kind of moved and we're like, let's not send anyone to treatment if we don't have to. That's outside of our system. Let's try to maintain everybody inside of our system. because we believe the least moves are the better, especially in rural Oklahoma, because we're usually sending people an hour to 2 hours away. Additionally, if you think about all the transitions you have to track over maybe a 30, 60, 90-day period, especially somebody goes to treatment, you really begin understanding that we're with people through a true episode of care. So many systems and so many people see that as long as I took care of this person's suicidality today, then we're good. The primary care doctor that sent Jamie to the emergency room, I'm good. I handled it today. But the episode is really 30, 60, 90 days of all that happened, all the transitions made, and making sure that you don't lose your person through the cracks, any holes that are in our system that we're aware of. And so I actually like the idea that in primary care, there's a designated person that's aware of all the transitions that are happening, because it really in Oklahoma can be so many. So many things have to go right for all the transitions to go well and to make the patient stay engaged in care and actually benefit from care. So remember that I haven't had one patient review that has said everything went as it needed to go when I left our system, got to the next place, got to the next place, got to the next place. In fact, they all tell me the opposite of all the ways they wanted to stop. They wanted to lie about their suicidality. They did lie. They didn't take their medications. They stopped their medications, all of the things. And so making sure that they stay engaged in care, meet all the transitions, stay on their medications, have the refills, all of those things is a lot of steps. And so I'm just asking you to think about how many steps do we ask somebody in crisis to go through, to where if we didn't send them to those many places and we manage them in primary care, we eliminate all the opportunities for them to fall through the cracks or potentially end their life because the care that they got was not conducive to what they feel they should be getting to manage their episode of suicidality. I asked my staff how often that our patient boarding in the ER waiting for a patient bed decides they're not suicidal. And they said usually at about 2 hours. If they know they're going to be waiting 3 or 4 hours for transport or going somewhere, they begin to change their story really, really fast and decide that they're no longer suicidal. Do we think they're no longer suicidal? They still are. They just don't want all the transitions that they're going to have to go through. And they really actually do just want help. So as I mentioned, the Joint Commission really supports managing people in transitions, managing people in your system, keeping track of them, having policies and procedures that follow up with people for the full episode of care beyond just somebody being in your office. This report, the R3 report, was the first evidence that I saw that the Joint Commission matched what their recommendations were with the Zero Suicide Initiative. And this was the document that I was able to present to our leadership to make a case for us doing things a little bit different in our system. How many of you work in Joint Commission accredited systems? What about CARF accredited systems? Okay. So all of that, just kind of a brief overview of Zero Suicide and the case for primary care management of suicidality. To share a little bit more about our implementation at the Chickasaw Nation. Again, we haven't arrived. We study our processes all the time and we make mistakes. And we, after 9 years and working on this manualized model and steps, still are implementing every day. Our integrated care is being refined every day. Our implementation of Zero Suicide is refined every day, but we truly believe that the trio of working in primary care helps us with ER diversion, and the implementation of integrated care was the basis for Zero Suicide, and Zero Suicide is the basis for our own reduction in suicides. So for those of you who aren't familiar or maybe from Georgia, the Chickasaw Nation is a federally recognized tribe located in South Central Oklahoma, southeastern Oklahoma, really. We are 7,600 square miles, which is really about 13 counties. The tribal population of the Chickasaw Nation is only 80,000 citizens, with more than 41,000 of those citizens living in Oklahoma, but not necessarily in our tribal boundaries. If you are interested in tribal boundaries and how the state of Oklahoma is divided up, that's easily Googleable. So we are responsible for the healthcare of all First Americans in these 13 counties. They don't have to be Chickasaw. They can be any tribal affiliation. We provide healthcare at no cost to the patient. Tribal healthcare systems are a separate entity from the Indian Health Service. If you want to increase your knowledge real quick, I would ask you just to write down the acronym ITU. And ITU are the 3 places that Native Americans can get their healthcare at no cost. ITUs stand for I is the Indian Health Services operated facilities. So those would not be operated by a tribe. They would be operated by the federal government, the Indian Health Service. T are healthcare systems operated by tribes. So that's going to be like the Cherokee Nation, the Creek Nation, the Chickasaw Nation, Choctaw Nation. Others like Osage and others that may have smaller hospitals. So those of us that moved from being an I to become a T, and Sarah, help me if I'm leaving something out. Those of us that wanted to be a T, we took the money that the Indian Health Service had for our area, operating the healthcare facility in the Ada area for those 13 counties. And we said, we think that we can take that federal money that the Indian Health Service has allocated to us, and we can supplement it by billing third-party insurance and run our health system better or different than the Indian Health Service. So we became a compacted tribe to become a T to run our healthcare system by billing our patients insurance. Again, no cost to them, but we do get paid for the services that we provide through those that have third-party insurance. People always ask me, what's the Chickasaw insurance, or what insurance do the Chickasaws have? Our patients have the same insurances that everybody else has. So we sustain our healthcare system on third-party revenue, and the I supplements our healthcare system. The U after the T are urban Indian clinics. There are 2 urban Indian clinics in Oklahoma, one in Tulsa and one in Oklahoma City. Urban Indian clinics have a very small amount of federal money to support their facilities, and the rest usually comes from grants or other private opportunities. We operate a large healthcare system. For us, we have over 1 million visits a year. We deliver 1,000 babies a year. Our emergency rooms like 4,500 to 5,000 visits a month. Our dental system is usually like 50,000 visits a year. So you can see that in Oklahoma, tribal healthcare systems really do impact the healthcare landscape in Oklahoma. Can you guys imagine, those of you that know, can you imagine healthcare or mental health care in Oklahoma without the robust healthcare systems that the tribes have? And Jessica says, absolutely no. So those that may be not a fan of tribes that you may know in this state, we do help the state out a whole lot by running really, really high quality accredited capable healthcare systems. So in the Chickasaw Nation, we have 4 locations right now, a main hospital in Ada, and then we have 3 clinics. But our largest venture yet is going to be in Newcastle, Oklahoma over the next 10 years. It will be the largest tribal health system hospital in the state. We are slated to have close to 7,000 employees there, 100 mental health clinicians in that location, and about a 3 million square foot campus. So prepare yourselves for that and send us all your doctors, because we're going to need a lot. So in 2014, as I mentioned, through Governor Anna Tubby's visionary leadership, we started integrated care. We started with the clinicians that were all working in a behavioral health clinic that was very stigmatized and very low functioning as far as the number of patients we were seeing. We started with 9. We asked all of the behavioral health clinicians that had never done anything with integrated care to be trained in integrated care and to move out of their offices and into the clinics. Half of them were really, really mad at us, and the other half were really, really excited. We formulated team care across our entire system. We did what we could with 9, and we've been working since then to grow more, to establish a fully integrated system. We now in our healthcare system are at 38. So from 9 to 38, we have made a lot of strides. We tend to try and have a ratio of 1 behavioral health clinician, or we call them medical family therapist, to 3 or 4 doctors. So we are aiming, especially for Newcastle in our new facility, if we can get staffing right, that every pod would have 1 MD, maybe a PA, APP, APRN, a few nurses, a medical family therapist, and a care coordinator, all located in each pod. So now we're staffing new doctors. Every time that somebody wants a new doctor, they have to say what therapist is going to be paired with them and how many nurses are going to be paired with them, so that we're not hiring in our system unstably staffed clinics, if that makes sense. So sometimes primary care is like, we're adding 7 doctors next month. And I'm like, what therapists are going to serve those 7? So thankfully, we've moved to thinking about primary care as a pod kind of system, where we make sure that all new primary care teams have a therapist assigned to them before we start them, which is really great. We have quite a few psychiatrists now, which are wonderful. Also trained in the collaborative care model, which we are venturing into, which is wonderful. And then we have multiple psychologists for adult and children as well, one with us today. Overall, we have 70 master's mental health clinicians across the full Chickasaw Nation. It's just those 38 are allocated to primary care and healthcare. Our medical family therapy team averages 15,000 visits a year. We've moved to add care coordinators to take the load off the therapist and the doctors and the nurses, to have more care coordinators that handle all the transitions we talked about. We've been able to finally be self-sustaining with $4 million for our team. We run about a $3.5 million budget, and I've just surpassed 4 million to be fully self-sustaining, so that we can tell people that people in mental health care actually can produce revenue. We have had 3 joint commission visits since I have been at the tribe. Our 4th is expected in between January and March. And we have not had 1 finding on any joint commission visit thus far for any of our suicide care management practices or policies that are modeled after zero suicide. Again, in the trio of things that I want to get tattooed on me that I think is important, remember that integrated care is in the middle. And I don't think suicide care management or zero suicide is possible unless you have an integrated care system. It would not work for me to ask all the nurses and doctors to screen everybody and to handle them and their suicidality without having a behavioral health clinician within arm's reach of them. But because we did integrated care first and we embedded our therapist in the clinics and in the emergency room, when we asked the nurses and doctors to screen or manage somebody who is suicidal according to their risk, they were willing to do it because we were either there as a consultant or literally there with them in the room to help them do it. The state of Oklahoma and Jessica's teams and the wonderful support of the grant writers for the state allowed us to learn about zero suicide. And were it not for the state, we would have never even heard the word zero suicide till probably 5 or 6 years later. We were taught zero suicide because the state received a grant, and we were the only tribal health system to begin our zero suicide implementation in 2016. We thought this was only going to be something that transformed our emergency room. And then people were like, why would you only do it in the emergency room when primary care really could catch more people, and people should be caught in primary care before they got to the emergency room? And so our system actually was open at the time because of the Joint Commission endorsement to moving it beyond just an emergency room project to be a full all system implementation. So all clinics, from the dental clinic to the audiology clinic to the physical therapy clinic to the hospital to all primary care clinics and surgery and cardio, all of them implemented the same standardization and standard practices at the same time. So you can imagine when you ask a dentist to do a suicide or depression screen, how that meeting goes. But once they had a suicidal person detected in the dental chair, we created believers really quick. So we are full system now with all screeners. We have a standardized practice and process that we use the same screeners in every clinic. In the pediatric clinic, we use the adolescent version of these. All of these are highlighted as part of the zero suicide protocols. We actually got it approved that all staff working in healthcare all have to have suicide awareness training. The thing that we didn't predict is everybody wanted to know what happens when somebody calls and says they're suicidal. The front desk person had no idea what to do. And the front desk person was also the person receiving somebody walking in off the street who just walked up to them and said, I'm suicidal. We didn't predict that. We didn't even know that all of those that worked at the front desk would want help with that and training with that. So we made a protocol for them based on some zero suicide philosophies and screeners. And we put the process for what they need to do with a suicidal patient on the phone or in front of them on a mouse pad for them that they saw every day. So everybody feels pretty comfortable now. We have a very clear process that if somebody walks in or somebody calls, we don't put them on hold. We don't transfer them. We don't take our eyes off them if they've walked in the door. And I think it's gone really well just because that mouse pad, honestly, trained them really well. It wasn't even us that trained them. The mouse pad trains them every day. One thing also that I had no idea we would be doing that the Joint Commission reminded us that we have to do is they said that a suicidal patient should never be left alone if they're at moderate or high risk. So they saw that we would have suicidal patients that we left in a room by themselves with numerous things in the primary care office and in the emergency room that they could use to hurt themselves. So the implementation of a one-to-one sitter, if you will, and a one-to-one observer in our primary care and healthcare practices was a huge heavy lift because of the staffing that it took to make sure that we implemented that. So that has been something that was not mentioned in the zero suicide model, but Joint Commission said that we had to have. So that's been a tough one, but we are successfully there now. Again, for the transition and follow-up, all of our therapists and behavioral health professionals now can recite in their sleep what happens with a suicidal patient beyond their day of suicidality. We do a safety plan with every patient. We work with the state's Heartline. We follow up with all of our patients within 72 hours by phone or in person. We track on a registry. You remember we learned the word registry today. We track on a registry all of the patient's moves or transitions through their care. So that patient registry is managed in Excel because we have a very Fisher-Price version of electronic health record. We're waiting to see if Epic can move us from Excel into something a little more bougie to manage our patients. I showed our new Epic guru who's guiding our system through Epic that we were managing it in Excel, and he about had a heart attack. He's like, where are you storing this? And all the questions. So we literally in Excel manage every single person that is suicidal on our team. They are labeled as red, yellow, green in the registry. They stay on the registry in their color until they move to the next level of risk. We have 3,000 patients on our registry from the beginning, and we have not lost one patient on our registry, which I'm very proud of. The registry has about 20 different data points. So for those data nerds, you can imagine the great data we've been able to get from Excel, because it was in Excel, to help us kind of learn a little bit more about our patients and the demographics and the trends of things in our system. So happy to share what that template looks like in its own Fisher-Price version in Excel, if anybody is interested in that. But it literally tells us the who, what, when, where, why for every patient identified at risk for suicide. If we happen to see them again, we just search the list and we look at what happened for them last time. It also always tracks them by what their current level of risk is, low, moderate, or high. So in our system, we've screened hundreds of thousands of patients since we began in 2016. I think the greatest accomplishment is that we no longer treat every suicidal patient as the same. Everybody has a different level of risk, and if you're low, moderate, or high, you get a different level of intervention and response. We have been able to divert from the emergency room consistently the entire time since implementation. We have had a huge law enforcement impact. So law enforcement is actually really happy with us that we don't send them on 60-mile trips to there and back. I would like to also make an endorsement for ride care in Oklahoma. If you're not aware, ride care is a third-party transport option that has changed the lives of our patients and how they're transported. It's available, I think, in every jurisdiction. The state showed me on the website who's assigned to what area of the state. But basically, we just fill out a form, and it is a non-law enforcement transport of our patient. They don't have to go in handcuffs if they're safe. They just go in like a regular car, not with a police officer handcuffed. And it's been wonderful. So we made a tribal contract similar to the state's contract with that service. Yes, it is fantastic. So now at least our patients are a little more comfortable, I think, than thinking they're arrested for being suicidal. Our partnership with the Heartline, I could talk about forever. The Heartline is unique to Oklahoma and follows all patients who are at risk for suicide that we send to them based on the patient's consent of being willing to be followed by the Heartline. It helps us on nights and weekends and holidays when our staff are not in the emergency room. Again, we have identified and detected people that are suicidal across all facets of our healthcare system. The dental office, the eye doctor, primary care, audiology, optometry, all of those. We are endorsed by the Joint Commission. We've had the opportunities to work with other healthcare systems here in Oklahoma. But really the thing that I think has changed our system the most and makes me be able to sleep at night is that I feel like we have standard practices and documentation. We no longer treat patients the same, but in our health record, in all of our processes for both the primary care doctors, the nurses, and our therapist, everybody knows the protocol. This is what we do for screening. We identify as low, moderate, high risk, and we give the intervention based on the level of risk, which I think has been really important. That was a lot, really, really fast. Thank you.
Thank you so much. I really appreciate you've mentioned the zero suicide that you have done for many years, and I really appreciate that overview that you gave us on that. I'm interested in that relationship with Heartline. I was telling Dr. Kate that Heartline had been in existence prior to the 988, and now it's integrated. From what I understand, I haven't had that use that, but I understand. What is it that you use Heartline for your patients?
Yeah, so Heartline for us, again, the state supports a contract for us with the Heartline. It's an estimated $30,000 a year contract, I believe, and we've had it for 6 years. And our patient signs consent, and the Heartline calls them and checks on them multiple times a week and keeps us notified about how the patient is doing. So if you can imagine, we don't have a mental health professional at night available. So not only can the patient call the Heartline, which is now a part of 988, or they can call the person that's been checking on them, but we know at all times by the Heartline giving us a report how the patient did the whole week that they weren't seeing us or in between appointments. It is awesome.